Hello.
Hello, ma'am.
Yes, ma'am. Yes, ma'am.
Can you hear me?
Yes,
Hello.
ma'am.
Yes, ma'am. You're right.
Okay. No problem. वीडियो ऑन कर ओके इसका ये वीडियो ऑन तो मैं करूँगी तुम इसको ले जाओ सॉरी तुम अमन का फोन नंबर होगा वहाँ जाके समझ लीजिए ओके तो एक मिनट ये जूम और कहाँ गया
Dr. Srivardhan, meanwhile, can you start the session proceeding?
Yes.
Please switch on your video.
Yeah. Am I audible now?
Yes, perfectly.
Okay. So, good evening, everyone. And this is going to be the first session of our critical care neurology subsections events for this year. And I thank Professor Dr. Kalita, who has been kind enough to initiate this events. Dr. Ray is currently unavailable today. He's stuck with the Heritage Conference. At the outset, I also thank the President, Professor Dr. Lakshmi Narasimhan, and Secretary Dr. U. Meenakshi Sundaram for all the support they have been providing to our critical care neurology subsection. Wasting no further time, we'll directly go for today's academic event, which will be presented by Professor Jayanti's team. And then we can decide and discuss certain other.
Hello.
Yeah, ma'am, you can start the session.
Okay. Good evening, ladies and gentlemen. So this was, I am really thankful to Dr. Partha and his team that they have selected as a PGI to initiate the Neurocritical care session online program. And we are having a very interesting patient, common problem, but there was diagnostic dilemma because of associated other problem. The diagnostic dilemma as well as the management issues, several management issues, what is important for the critically ill patients. Those points will be discussed. Dr. Sahej will be discussing the case in detail, and Dr. Prakash Pandey, who will be analyzing the management issues and how we dealt with the at different stage in the diagnosis as well as different complication issues and how the patient has come out. Now I request Dr. Sahej to go with the case. Thank you. Dr. Sahej has joined the program.
No, ma'am, she has not joined.
So she could, okay, okay. Where is she? I'll just, she was here only, she prepared the slide probably. I'll just find it out. Okay. Prakash, can you find out Dr. Sahej? Is he having some problem? Dr. Sahej को बुलाओ तो
Dr. Prakash, if possible, can you start your presentation first? Hello. Hello.
Hello. She is just uploading her slides. Okay, share the slides.
Please, ma'am. While the other participant,
That's it, huh?
ma'am, they're telling that.
Hello?
Participants probably not.
Yes, ma'am.
Hello. Can you allow her to upload
Yes,
the
yes.
slides?
Yes, yes.
Okay,
She can
please
start
allow because she will hook her because she could not use her laptop. From here only she will use it. Please
Yes,
allow
yes.
her.
Yes,
Okay.
yes. She can share the slides.
एक person है अभी उसमें है। सुनो अनु क्या है तुम्हारा क्या चाहिए कुछ नहीं तुमको
Dr. Sahej, can you share your
Yes.
screen?
Yes, ma'am. I'm displaying the slide, ma'am. Can you all see, ma'am?
No, no, not yet. You have to just go back to the Zoom. There is an option of share. You have to just click that share icon first.
Zoom के थ्रू से जाना पड़ेगा तुमको
मैम यहाँ से होगा शेयर शेयर मैम
लिंक से
शेयर शेयर मैम
ओके चलो यहाँ पे तो यहाँ से आ जाना चाहिए ये है ना तुम्हारा स्लाइड है ना दिस वन हाँ करो हाँ कैन यू सी
मैम
Yes, yes. Put it on the
Okay.
slideshow mode.
ओके स्लाइड शो नाउ स्टार्टेड
Yes, ma'am. Very good afternoon to all of you. I'll be presenting the case of a diagnostic challenge in managing a common disease in ICU. So I'll be presenting a case of 21 years male, right-handed, resident of Lucknow, with a history of road traffic accident 3 months back, followed by loss of consciousness for 1 hour, with multiple episodes of vomiting. He suffered right tibial and patellar fracture, for which he underwent open reduction with internal fixation with tension band wiring the very same day, followed by he was advised 4 to 5 days of rest. After that, he started using walker, and with the help of walker, he would walk for the next 3 months. And this is the X-ray that you can see showing right tibial and patellar fracture, which was operated the very same day. And as you can see, this is the lateral X-ray of the very same patient showing the rod plating and the wiring over the knee. And these are the post-op photographs showing the wound the patient was having. This is the post-op day 8 and post-op day 10 photographs. The patient presented to us with the chief complaint of fever from past 3 months, which was intermittent, and it was associated with a recurrent sinus discharge from wound, which was present over the right lower leg, which you can see in the photograph. And patient was also having an history of headache, which was there from past 4 months, which was a mild to moderate in intensity, associated with photophobia and phonophobia. But this character started basically the day prior to the admission over here. He had at around 6 p.m. in the evening, he suddenly had severe intensity headache, followed by 2 discrete seizure episodes, which were focal in nature with secondary generalization. His face was deviated towards the left side with the tonic-clonic movements of the right upper and lower limb, followed by patient was having altered mental sensorium since then. And with these complaints, he presented to us at SGPJ hospital. The patient had a past history of migrainous headache from past 3 years, which was there for 2 or 3 times a month for more than equal to 4 hours. And there is history of 6 to 7 episodes of seizures over 1.5 years. At the age of 12 years, that point of time, he took Ayurvedic medications, which he took for 3 years, and the seizures never recurred till the 1 day prior to the admission. This 21 years old male used to take less sleep because of excessive mobile usage with normal appetite, with normal bladder bowel habits. He was non-alcoholic, non-smoker with a history of tobacco chewing from past 5 years. He used to consume mixed diet, and there was no family history of seizure. And he was on the following antibiotics from past around approximately 3 months. And starting from 14th of September, he got operated on 26th of August. After around 15 days of road traffic accident, he was on these broad spectrum oral antibiotics like lansoprazole, initially on cefixime. After that, he was predominantly ferropenem plus clavulanic acid was used along with clindamycin as well as cefuroxime. And he stopped his antibiotics just 10 days prior to the onset of symptoms. While on his initial presentation to our hospital, he was found altered, confused, not cooperative. His vitals were stable, and he was having low-grade fever with the 98% of oxygen saturation at room air. Pallor was present with the right leg sinus serous discharge was present. On systemic examination, it was normal, no abnormality detected. On neurological examination, his GCS was E2, V4, M5. Here, meningeal signs were present, neck stiffness and Kernig sign were present. Rest of the neurological examination, as much as we could do, it was normal. Sensory and cerebellar examination could not be assessed. So coming to the summary, in view of young male having fever, headache, seizure, that also focal seizures with secondary generalization, with altered mental sensorium, with meningeal signs being present, and with the discharging sinus over the right lower leg, the possibility of pyogenic meningitis with or without cortical abscess was kept. The etiology being probably partially treated pyogenic meningitis, etiologically bacterial versus fungal versus tuberculous was kept. Keeping this thing in mind, NCCT head was done on the very same day of admission, which did not show any focal lesion. CCT head was done the next day, and which did not show any meningeal enhancement or any focal lesion, a focal parenchymal lesion. Coming on to the investigation, CSF was done the next day of admission, which showed total cells of 145 with the lymphocytic predominance, with the slightly elevated protein of 65.4 milligram per deciliter. On CSF gram stain and culture, it showed methicillin resistance coagulase negative staph, which was sensitive to doxy, teicoplanin, and vancomycin. Rest fungal microscopy and culture, it did not show any growth, and CSF AFB and gene expert MTB was not detected. Coming to the investigations, there was anemia, which was normocytic normochromic anemia with the initial, at the time of presentation, his TLC was 3.5 with neutrophilic predominance with the elevated ESR, and his creatinine was normal at the time of examination throughout the hospital stay. And there was hyponatremia, which during the course of hospital. Coming on to the serum electrolytes, which were maintained throughout the hospital course. And CK initially at the time of admission was 1233, which got normalized after around 10 days of admission, and rest coagulogram was normal. HIV, HBs antigen, anti-HCV antibody came negative. His urine analysis was normal. B12, folate, and vitamin D, they were rather a little bit on a higher side, probably because of the supplementation he was getting. His TSH was normal. Coming to the in view of his fever spikes and headache with the meningeal signs, his procalcitonin was also sent, which was found elevated 14.39 at around 2 to 3 days after the admission. So I'll come back to this slide after a while. So I'll just discuss it right here. So his firstly I'll come to the course during the hospital stay. So at the time of admission, the patient in view of fever, headache, meningeal signs, and seizure history, the patient was started upon ceftriaxone 2 gram BD along with tablet levetiracetam 500 mg BD with clobazam 5 mg OD. The next date, that is day 2 of admission, patient had episode of GTCS followed by status epilepticus. He had the convulsive status epilepticus. His airway breathing circulation was maintained. Vitals were monitored. His blood glucose was normal at that point of time, and he was given injection lorazepam 2 mg intravenously. But the seizures did not stop. So we repeated the lorazepam 2 mg IV after 5 minutes twice, with the loading dose of levetiracetam was given. Along with the dosage of levetiracetam was increased to 500 mg TDS from 500 mg BD. Along with clobazam dosage was also increased from 5 mg to 10 mg. Plus carbamazepine 300 mg BD was added in view of seizures being focal initially. On the day 2 of admission in the evening, in view of persistent tachycardia, that is around 152 per minute, and tachypnea 52 per minute with convulsive status epilepticus ongoing, he was intubated, and along with that, his IV lorazepam was given again, which was repeated in the evening as well. After 5 minutes, 2 dosages were given. And the tablet, in view of ongoing convulsive status epilepticus, his carbamazepine dosage was increased from 300 mg BD to TDS. And immediately post-intubation, patient required inotrope support, and he was started upon single-strength noradrenaline at the rate of 5 ml per hour. On day 3 of admission, his GCS was E1 BT M2, and bilateral pupils were symmetrical, bilateral plantar were flexor. In view of persistent fever and poor sensorium, possibility of non-convulsive status epilepticus was kept, and EEG, bedside EEG was done, which showed generalized background slowing. And in view of that possibility, clobazam dosage was increased from 10 mg BD to 15 mg BD. And his procal, as I had just showed, it came out 14 on day 3 of admission, because of which, in view of persistent fever spikes, patient being in shock, and possibility of pyogenic meningitis highly likely, his antibiotics were upgraded to meropenem 1 gram TDS and teicoplanin. On day 4 of admission, his GCS, patient GCS was E1 BT M4, and his NORAD requirement increased to 6 ml per hour. His pupils were symmetrical, fever was persistent, and his seizure frequency reduced. But still, the convulsive seizures we could see, because of which his levetiracetam dosage was increased from 500 mg TDS to 1 gram BD, along with continuation of clobazam 15 mg BD and carbamazepine 300 mg TDS. On day 5 of the admission, patient's GCS remained almost the same, E1 BT M4, and his NORAD requirement reduced slightly to 4 ml per hour. Rest of the parameters were almost the same, except that his seizure frequency reduced to 3 to 4 times per day. And but the anti-seizure medications were continued. On day 6 of admission, the GCS remained the same, the NORAD requirement reduced, and the seizures, there were no seizures from day 6 of admission, and his anti-seizure medications, same medications were continued. So one thing over here I want to discuss, that in view of, if we consider the whole clinical scenario of this patient, 21 years male, chronic fever from past 3 months, along with the meningeal signs, along with his CSF showing lymphocytic predominance, and cellular CSF with the lymphocytic predominance, and exclusion of fungal etiology, he was fitting into the diagnosis of probable TBM. So I'll be briefly touching the diagnostic criteria, which is of tuberculous meningitis, which is based upon clinical MRI and CSF criteria. The essential criteria being the clinical features suggestive of meningitis, fever, headache, vomiting with or without focal neurological deficit or altered mental sensorium for more than 15 days. So our patient over here has more than 15 days of fever, headache with vomiting with the altered mental sensorium. And the supportive criteria, two supportive criteria needs to be fulfilled to label the patient as probable TBM, which he did have CSF cells of 145 and the second time 245 and CT or this that at this point of time the patient exclusion of alternative diagnosis it was fulfilled, so he was labeled as probable TBM and he was started upon on day 7 his ETT. He was started upon ETT, first line ETT HRZD. At day 7 of admission, patient's GCS was even VTM4, which was the same. And his inotrope requirement, he became off NORAD on day 7 of admission. His pupils were symmetrical at that point of time, and his fever was still persistent. He was continued on meropenem day 4 and teicoplanin day 4 with no recurrence of seizures. On day 8 of admission, his in view of persistent fever spikes, and CSF gram stain culture grew methicillin resistant coagulase negative staph, because of which he was started upon vancomycin, which was sensitive. Antibiotics it was started, teicoplanin was stopped, and on day 8 of admission, a repeat bedside EEG was done to rule out non-convulsive status epilepticus. In view of his poor sensorium, which again showed generalized background swelling with no epileptiform discharges. And in view of no recurrence of seizures from past 48 hours, his clobazam dosage was reduced from 15 mg/BD to clobazam 10 mg/BD. On day 9 of admission, there was an improvement in sensorium. There was from E1 VTM4 to E1 VTM5, and his NORAD requirement again it was started on day 8. Which continued on day 9 as well, and there were no seizures. His fever spikes were still persistent, and he was continued upon meropenem day 6 and vancomycin day 2. His paracinamide was withheld on day 9 in view of deranged LFTs. HRE was continued that day. And further on day 10 of admission, the patient's GCS remained the same, E1 VTM5, and NORAD requirement reduced slightly to 1.5 ml per hour. On day 10 of admission, his pus wound swab culture came, which was taken from right leg. The photograph of which I had showed earlier. So in that, the organism grew was Enterobacter cloacae, which was sensitive to colistin only. So on day 10 of admission, the patient was started on colistin day 1, and because of colistin, we just stopped the vancomycin. And we started the patient on doxycycline, as a methicillin-resistant coagulase negative staph was sensitive to doxycycline as well. So the patient was started on doxycycline and colistin on day 10 of admission, with the local dressing of wound was done with colistin as well. And there was no seizure recurrence. Coming on to day 11 of admission, the patient's GCS was GCS improved to E2 VTM5, and his antibiotic remained the same. There was a slight reduction of fever. At that point of time, on day 11 of admission, he was started upon propranolol long-acting in view of cerebral salt wasting. Basically, the patient was having hyponatremia along with increased urine output, despite giving less of intake as well. So propranolol long acting was added with no seizure recurrence till this day as well. So he was his clobazam was reduced from 10 mg/BD to 5 mg in the morning and 10 mg in the evening. And on day 12, day 13 and day 14, his GCS remained the same, E4 VTM5. And in between, his fever spikes also remained almost the same. His right leg started, wound started healing. There was repeat CSF and gram stain culture sent. At the second CSF showed increase in the cells with the neutrophilic predominance. 70% of neutrophils were there, with the gram stain culture being sterile this time. And his antibiotics remained the same. He was given TP's trial, which he tolerated for next 48 hours. So he was extubated on day 16. and he was continued upon meropenem, doxycycline, and colistin. HRE was continued, and propranolol was also continued in view of cerebral salt wasting. Coming on to day 17, day 18, and day 19, his sensorium remained good in the form of E4, V2, M6, and but he still required oxygen saturation. He still required oxygen requirement, which was at the rate of 4 liter per minute in view of his secretions. So laryngeal suction was done, and the secretions were sent for culture. And his after completing meropenem 14 days, he was shifted on ceftazidime and vancomycin. Colistin was stopped after day 10. This was the chest X-ray was repeated in view of persistent fever spikes, which did not show any infiltrates. Coming on to day 20, the patient's GCS remained almost the same in E3, V2, M5 over the course of his next 3 days. And but he had to be reintubated in view of labored breathing and persistent tachypnea on day 22. And his fever spikes were persistent. Repeat procal was sent, which came normal. CSF culture was again repeated. And this point of time, in view of no improvement in sensorium, repeat NCCT head was done on 29th of December, which showed in right capsuloganglionic infarct, which you can see over here in these sections. So in view of this was another supportive criteria which indicated towards tuberculous meningitis. So we continued on ATT along with the patient was tracheostomized on day 23 in view of prolonged intubation, and along with the continuation of their antibiotics, ceftazidime, vancomycin, and linezolid in the due course. Patient was started upon linezolid and amikacin as alternative ATT. As his LFTs were deranged. He was given a trial of rifampicin, but in view of rising LFTs, that was stopped. On day 35, the patient's sensorium improved. As his sensorium was improving, his tracheostomy stoma was closed on day 40 of admission, and his antibiotics all the antibiotics were stopped apart from modified ATT, and he is still continued on amikacin, linezolid, ethambutol, and isoniazid has been initiated, which he is tolerating, and the patient is planned for discharge. Now, this is the line diagram showing the serum sodium values, his urine output in the green over here that you can see. Just after his on day 2, his day 3, he started having this urine output used to be urine output was more than intake, and at that point of time we added propranolol. After that also his urine output did not improve, so we had to increase the dosage. After that, over the due course, and now he is having almost normal intake output. He's maintaining that, and this is the diagram which is showing drug-induced, basically the LFTs trend. Initially at over here 15 December he was started upon ATT. After around 15 days, we had to stop the ATT in view of rising LFTs. After that, we gave him slowly, we added alternative second line ATT drugs. We tried to initiate rifampicin again, but but after 3 days, we had to withhold because of deranged RFTs. And now we have added INH, which he is tolerating well. And now at the time of discharge, this is just today's photograph. He is E4, V5, M6. He is tracking objects. He's opening his eyes spontaneously. He's following commands, and he's oriented. And this is the wound at the time of discharge, which has healed. I'll be inviting Dr. Prakash Pandey sir for his for the analysis. Thank you very much.
Dr. Prakash?
Ma'am, sir, please stop your screen sharing.
Okay, we have to, okay, so it should, okay, okay, gone, okay. Is it okay?
Yes, ma'am, it's okay, ma'am. It's visible.
Okay.
Ma'am, is visible.
Yes,
Well,
it is.
it is visible.
Ma'am, good afternoon and good afternoon, everyone. I am Prakash, going through this case for analysis. There are the 5 issues in this patient. One of these is one of them is in diagnosis, and other one is in management issues. I will be discussing one after another, highlighting our departmental experience in this particular area. First of all about the diagnosis. As Dr. Sahaj has told that in a repeat CT scan showing hypodensity in the basal ganglia region, which is a suggestive of infarction. Now, stroke could be seen in pyogenic meningitis as well as in tuberculous meningitis. The location of infarction could be suggestive of diagnosis. In pyogenic meningitis, usually the exudates go and settle into the sulcal spaces, but in tuberculous meningitis, the location is basal. That's the reason why in pyogenic meningitis, the infarcts located in peripheral regions, and in tuberculous meningitis, due to perforators, the location lies the deeper areas in mainly tubercular zone. Our departmental studies has shown that actually the majority of the patients have the deeper stroke in basal ganglia region and with or without other areas of involvement. How in this study also it was shown that stroke long-term outcome is independent of stroke. In our population, we could think that's this location of infarct, location of hypodensity, which gives a clue, and that's why we have started anti-tubercular treatment. Initially, our patient have now the second issue is the seizure. Our patient initially have discrete seizures after admission develops status, which continued for around hours. The status epilepticus, how common in central nervous system infection? Long time back, our faculties have done research in this field as in infection as a whole, and it was found that around 40% of the cases of status belongs to infection, and out of them, around 18% of the 13% of patients are having tubercular etiology. This follows that status epilepticus in this patient, this fellow have got status epilepticus. We have given lorazepam followed by levetiracetam, which is good drug to treat. In our departmental experience, we have found that all the second line drugs are more or less equally efficacious, but we should think about their side effects. This patient have refractory status epilepticus. How different status epilepticus in TB meningitis? We compare it with scrap typhus also. Although both are bacterial meningitis, scrap typhus patients have better outcome. We have seen in this study that none of the patients showing poor outcome. All of the patients will survive. However, in tuberculous meningitis patients, the status epilepticus used to be refractory and with high mortality rate. Still, at the end of 1.5 months, our patient is wheelchair bound. Now, we have also done some basic research work in this field and found this that superoxide dismutase, serum GSH, MDA, and serum protein carbonate have significant relation with having oxidative endoplasmic reticulum stress in tubercular meningitis, leading to status epilepticus. Now, the another issue is the mechanical ventilation. What is the actual outcome in a mechanical ventilated patient of tuberculous meningitis? In our previous studies, we have seen dengue and scrap typhus both have the best outcome in when being mechanically ventilated. But when we have analyzed the tuberculous meningitis patient in this regarding, we found that around 80% of patients died and 20% patient having poorer outcome. This concept leads to genesis of another staging, stage 4 of tuberculous meningitis, or BMRC MB staging. And this also highlights the region of intubation, the region of ventilation is very important for prognostication as well as dissecting out the disease. In our patient, the patient got intubated, got mechanical ventilated due to status itself, not due to disease per se. Now the another issue is hyponatremia and cerebral salt wasting. Studies have shown that around 60% of tuberculous meningitis patients can show hyponatremia, but in our cohort, around 45% patients have some sort of hyponatremia. Even after excluding the drugs like mannitol and diuretics, the disease per se, due to there is hyponatremia. Majority of the cases belongs to either cerebral salt wasting or syndrome of inappropriate ADH secretion, SIADH. In our cohort of patient, the majority of the patient belong to cerebral salt wasting. This hyponatremia ultimately may lead to hypovolemia and Bardet zone infarction. In hypovolemia could lead to Bardet zone infarction in tubercular zone in hypovolemic phase. We have also done some basic work in cerebral salt wasting, and we have shown that the sympathetic dysregulation could be a reason of this hyponatremia induced by cerebral salt wasting. Initially, we have done a randomized controlled trial with fluorocortisone, but due to some in this random RCT, we have shown the early normalization of sodium, serum sodium, but the volume volume correction, it takes time as well as control arm as well as fluorocortisone arm. Being a sympathetic dysregulation, recently we have done a randomized control trial. The paper is in advanced stage of publication in BMJ Neurology, in which we use propranolol, and we have seen that correction in hyponatremia as well as in hypovolemia, both is significant in comparing to comparator arm. Now, the fifth issue is drug-induced hepatitis. Now, how to diagnose? If a patient having normal liver function before initiation of antitubercular treatment without alcohol use, and the standard antitubercular treatment given for at least 3 days, there is no apparent cause, and after removal of antitubercular treatment, there should be normalization or more than 50% improvement in abnormal liver function test. And these patients, either their enzyme increase to 5 times of normal without symptoms, or 3 times with symptoms, or total bilirubin more than 1.5 milligram per deciliter. Now, we are seeing more patients with drug-induced hepatitis than other diseases. We have seen that around 40% of the patient of tuberculous meningitis is suffered from drug-induced hepatitis in their course of illness, and this drug-induced hepatitis related to their severity of illness, and which is ultimately due to their accompanying inflammatory response due to physical stress. Now, after improvement of the liver function, the reintroduction, the sequential reintroduction, first of all isoniazid, followed by rifampicin, and at last the pyrazinamide. We found that around 40% of the patient leads to interruption in antitubercular treatment. This problem raises a question, and our institute have done another randomized control trial about sequential introduction of antitubercular treatment on initiation itself, and we found that sequential arm have shown significant decrease in hospital mortality, better 6-month outcome, and have fewer drug-induced hepatitis cases. In our patient, though we have started the conventional ATT, but later on we have to switch to sequential arm, and now at around as Dr. Sahaj has seen, around end of 1.5 years, half months, patient in this current state.
दायां हाथ उठाओ. बायां हाथ,
There is a
दायां
possibility
पैर,
for left side due to stroke.
बायां पैर, अमित दांत दिखाओ बेटा। ठीक है।
Now I'm inviting Professor Jayanti Kalita Madam for concluding remark. Thank you.
Hello. This is an interesting patient. Although tuberculosis meningitis is the commonest cause of chronic meningitis in India, specifically in northern India, but this patient foxed us for a long time because of discerning osteomyelitis and sinuses. Whether he had tuberculosis meningitis to begin with or he had multiple co-infections, it is difficult to assess because once we grown bacteria which is methicillin resistant, and later on, of course, from the past, we got cholesterol sensitive organism. But clue to the diagnosis was the infarct, which is located in the basal ganglia, whereas we get the infarct in sulcal or surface, towards the surface in pyogenic meningitis. And this case illustrates that how difficult to manage the tuberculosis meningitis, at least the period of 6 weeks. It is not straightforward that we are giving ATT and patient will respond. This patient had drug-induced hepatitis, he developed hyponatremia, cerebral salt wasting, and he developed infarction as well, and later on he came out. And although he had a ventilator, in earlier study already Dr. Prakash has said that what we saw, that TBM patient, if he is requiring ventilator because of hydrocephalus infarction or disease process, their outcome is extremely poor. 80% patient died and 20% patient had poor outcome at the end of 6 months. But this patient improved by 2 months. At least he can lift his hand and he came out from ventilator because his intubation was done, ventilation was done because of status epilepticus. Therefore, it is very, very important to know what is the reason for intubation. Not only in the primary disease process, it is important to know the disease process. And it probably will be happy to take the questions. And if the chairperson and secretary would like to comment on this subject, they are most welcome. Thank you.
Hello, ma'am. First, I would extend my congrats to the team for having taken the effort to present such a wonderful case. As Madam mentioned, this overlap of TB with other infection is quite common in India, but it's almost impossible to differentiate them. And in some cases, we start with empirical ATT. In your particular patient, again, the patient ended up with a drug-induced liver injury. So there are multiple obstacles at every point of time. There were seizures, there was a component of hyponatremia, drug-induced liver injury, systemic infection running around, and the way it was presented as if we were the patient on a daily basis, and the temporal evolution shows how committed the team has been in managing this patient. So thank you, ma'am, for this wonderful case. And I think we have a lot of learning points. And as we say, TB is a master masquerader, but I didn't know you would use CT to differentiate in pyogenic. That was a really good point which you mentioned. Based on the location of the stroke, how it helped you in suspecting that the patient might be having TB meningitis as a co-infection. So that was a really wonderful presentation. And any doubts or any questions, we will try to answer them.
Okay, probably.
But there are a few questions here.
Okay, you can answer, Dr. Prakash. Probably these are questions.
Aditya have asked about, I think before sending home, MRI brain should be done. Actually, patient has a metal plate in his lower limb. That's why even from MRI console, he was returned back. So that's why we are unable to do that.
There are a couple of other questions, ma'am. One question is, what is the role of melamine?
Melamine for what? Why do you want to give? I don't know. Means, is the Sutiction can tell Basudeba? The melanin I have not used for these sorts of patients. So I don't know. Means, Dr. Prakash, do you know any use of melanin in this particular patient?
No, madam. Not at all, ma'am.
Actually, this patient, that's right. Probably what he asked one thing, that MRI before the discharge. MRI we could have done at the beginning also, but that might have given us clue about the infarctions. We could have started ATT earlier. But this patient had metallic plating, which is not amenable for MRI study. That was the reason why it was not done. And at the beginning, he was convulsing. So convulsing patient sending to the MRI gantry will not be feasible. And therefore, we resorted to CT scan. And contrast image we have done on the next day, not in the same day, probably at the night. His creatinine may not have been known, he was on ionotrope. Therefore, they may not have given. But on the next day, if you see the contrast, again, the contrast image is not very good quality because they have taken immediate image. Therefore, you have seen a lot of vessel written up. So rather than seeing the enhancement, you are seeing the vessels and the sulcal vessel as well. So therefore, exudates in this particular image, we could not comment. So because a little bit later, 2-3 minutes later, image might have given more contrast enhancement. And moreover, one should know that if the patient is having raised intracranial pressure, the cerebral perfusion is slow. So in this situation, the contrast enhancement may be little later than the normal individual. So therefore, these are the issues. Probably we have to find it, we have to see. And ideally, a contrast, this is the answer. Did the patient have steroid for the diagnosis of TBM? Would you like to say he was given steroid?
We have given steroids.
Okay. Not at the beginning, but when we thought it is a tuberculous meningitis, we have seen that he has infarction in the basal ganglia, he was herniating. In fact, before the CT scan, the same person who was having normal movement, he became quadriplegic and he was hyperventilating, deeply comatose. And that time we have repeated the CT scan, and to our surprise, he had basal ganglia infarct. So then we realized probably, and at that particular moment, his lower limb reflexes, some of the reflexes were not elicitable. That means he is a case of chronic craniospinal meningitis, and minor radiculopathy is a feature of tuberculosis. That has another clue for us to go more aggressively for tuberculosis treatment. Otherwise, probably these are two clues. One is your basal ganglia infarct, another is your quadriparesis, and some reflexes were absent. And although there was no FP, gene expert was negative, there was no TB contact. Probably these are probably we have to think what common disease and how we can go about it. But at the same time, we cannot say that he is not a case having co-infection with other bacteria because he is discharged as sinuses, the colistin sensitive organism, MRSA in the CSF, MRSA sensitive, methicillin sensitive, or staphylococcus in the CSF. So it might be co-infection, and specifically when the patient is in the hospital for a longer duration, then they have immune suppression, and then one can have flare-up of tuberculosis. This is another important thing to remember. Many chronic patients may be admitted for other reason, but during the hospital stay, they may have activation of their tuberculosis because in India, I think all the doctors 100%, and in the common people, more than 80% are having latent tuberculosis. So therefore, this is very important to, this case highlight all the issues. And the monitoring of the TBM patient, it is not the blanket cover of TBM patient will go just like that. You have to keep on seeing and managing. So this is probably illustrate that how closely you have to monitor and treat the patients.
Hello, good evening. I'm Dr. Subsection. Can I speak, ma'am?
Yes, definitely, please.
Thank you. Very difficult case and wonderfully managed. One thing, the status epilepticus, once it was there, then role of ketamine. Sorry, it was miss.
Yes, you have written
ketamine.
Okay.
Sorry, ketamine. And
Okay.
second is key for hyponatremia. In case SIAD was there, so carbamazepine could have been stopped.
Later on
That is the
was stopped.
culprit.
Yes. Yes, thank you. Thank you for your concern. But ketamine, okay.
Ketamine is in status.
For your information, though
Yes.
whatever we have done at least 4 or 5 trials on status epilepticus, and what we have found that in the second line, whatever you use, it is more or less efficacy is same. Ketamine, one can give it, but I usually don't knock off the patient because I believe, and there are results also. If you see, people don't cite those papers. In Green Journal, you can get an article that patients who are intubated and ventilated because of status and produced anesthetic agent, deep sedation, and brain your EEG suppression. Those patients had more infection, more death, and more longer duration of hospital stay. So therefore, it is a double-edged sword. So usually in last 35 years, we are happy not to anesthetize deeply to the patient. We have hardly done brain EEG suppression in 2 patients. And in those patients, one patient died, other one survived, and rest of the patient, we have good outcome. Then the reported series. Because this patient also, if you see, the person's status, reproductory status, we have given in your levetiracetam and clobazam, and carbamazepine initially was given when he did not have hyponatremia. Later on, we have withdrawn that. And in spite of that, initially he was having discrete seizure. Then we escalated clobazam. Then we thought, is he having non-convulsive status? We have not shown the EZ. He had only slowing. He did not have seizure discharge suggestive of your non-convulsive status. Therefore, we have reduced the clobazam from 15 BD to 10 BD. And these are probably, you have to balance your patient and customize the treatment. So, and same patient having distinct seizure, on third day, he is not having seizure. So therefore, what we practice, suppose patient is having convulsion status, we manage. If there is a discrete short-lasting focal seizure, we don't change it much. It terminates of its own over a period of 2 to 3 days. Otherwise, you will be ending up with giving 8-9 drugs, and that kills the patient. Then hopefully you can see the result of this patient in spite of not anesthetizing. Ideally, more than 3-4 hours, you should go for very heavy dose and you can manage it. But he came out. So therefore, these are another thing you have to understand: the management of CNS infection status and de novo status epilepticus are two different things. The CNS infection patient already their brain cell are generalized inflammation, and on top of that, they are already unconscious because of the disease per se. They are herniating because of disease per se. They are respiratory compromised already because of disease per se. In this particular patient, if we give lot of midazolam or some other anesthetic agent, they are likely to have your respiratory suppression and cardiac suppression. Then it is difficult to bring them back. Therefore, one should customize and try to patient should not die of status. At the same time, patient should not die of treatment. That should be the main aim of treatment. Thank you.
Thank you. Thank you.
Dr. Jayanti, I would just ask one question because there is a lot of doubt here. Did the patient get steroids for the diagnosis of TBM? Is there a role of steroids in TBM with infarct? I just want to ask you one question, ma'am. Is there any scenario where we don't use steroid in TB meningitis?
Okay, TB, what you want the steroid in TBM?
Yes, ma'am. Is there any scenario where we don't use steroid in TBM?
Yes, actually, when in 1990s, when we were resident, I was resident in 91. So initial 10 years, we did not use steroid. So in fact, we have done a trial on middle DST funded project on, this is the first study of SPECT changes in TBM. And in that, we have seen that giving even MPS, we thought it is a vasculitis, we can give 5 days MPS followed by steroid versus no steroid. Then we did not get any change in cerebral blood flow, MRI finding, and outcome of the patients. So we were not giving, but later on when the meta-analysis and other things showed that mortality and outcome may be better, Dr. Kameswar Prasad had done your Cochrane review. Then because of medical legal problem, we started to use steroid, but not as high as Dr. Thwait using. We give steroid because one should know that it is a same thing is double-edged. One way the patient is immunosuppressed, therefore their tuberculosis is reactivated. But on the other hand, because of cytokine liberation and other thing, the ongoing damage, we have to give little steroid. What we do, we give 0.75 milligram of prednisolone. Unless patient is herniating or pupillary asymmetry, then we give dexamethasone, 8 milligram 3 hourly, then gradually we taper it off. And if patient is not having features of herniation, then we give 0.75 per kg, maximum up to 40 milligram for a month. Then we taper off in the next month. And if there is any paradoxical reaction like tuberculoma, then we escalate the dose. This is the way we balance. And we give aspirin. In fact, that was the trial we have done in 2010. Dr. Pradeep Nair was there. That time we have done that role of aspirin. It is the first trial in the world. That role of aspirin in preventing stroke and mortality. So in that trial, what we saw that the mortality benefit is there, that outcome benefit is not there. But definitely this may tide over the crisis by adding aspirin. Then we published in Neurology India 2 groups. One is not given steroid and aspirin because we had a cohort of earlier patients. Another group given only steroid. Another group has given steroid and aspirin. Then what we found, if we add steroid and aspirin together, they are doing little better than the other group. So probably now we practice giving 150 milligram of aspirin unless there is some complication of gastric bleeding or other thing, and steroid not going beyond 40 unless patient is herniating. That is the practice we do.
So you restrict to 150 milligram aspirin, madam, not
No,
the
yes.
300 milligram.
Not higher dose, not higher dose. In fact, this was in one of the American Neurological Association meeting. I was the panelist there, and they thought that 150 milligram is a tiny dose. The other panelists were arguing. Then I told that even aspirin, your 5 milligram is good enough to knock off your platelet unless you have a genetic mutation about the enzymatic pathway. So 150 is good enough. But if the patient is genetically abnormal, they need usually higher dose, even 350 BD also maybe. In earlier days, during my residency, the regular aspirin for a stroke patient was 350 milligram BD dose, 450 or 350. But not that has gone to OD, then to 150. But probably one should think, because from China in a large cohort, they have shown that insulin resistance is very common, and they have shown the genetic aberration, mutations. That type of study is in India not there. And if you see many more of your routine ischemic stroke patient, they are on antihypertensive aspirin, but even then they develop recurrence of stroke. Probably our cohort, whatever the genetic data for aspirin, your enzymatic pathway mutations, that has to be probably thought of, and we should know about it. Then we will be able to know this patient we have to give higher dose.
There is one more question, ma'am. Was non-tuberculous mycobacteria thought of since there was a discharging sinus?
Okay, what is that?
Was non-tuberculous.
Non-tuberculous mycobacteria.
Okay, non-tuberculous microbacterium, we have seen the discharging pass for organism, both for tubercular as well as pyogenic and fungal. Those are not grown. Usually it is grown or it is seen. We got one patient who was on mycophenolate and he had skin lesions. So in that patient, we had atypical bacteria grown. But in this particular patient, there was no atypical microbacteria, and neither in CSF nor in the discharging pass from the osteomyelitic site. So therefore, we did not diagnose. We thought as a probable case of TBM, we have managed this case.
I don't think we have any further questions, ma'am.
No questions. No. Okay. Where is Dr. Partha? Partha is not here.
Dr. Partha is stuck with some heritage meeting, ma'am. So he told he's not able to join today.
It's okay. No problem. No problem. It was a very short notice. We could have to arrange this. So it's okay. No problem. But in the process, we interacted. That is nice.
Sure, ma'am.
Okay. Thank you. Then thank you so much.
If there are no further questions, then thank you, ma'am. Thank you again for this wonderful case presentation and for the excellent discussions we had. Thank you very much.
Okay. Thank you so much. Thank you.